Hey everyone, it's Dr. Wood, and today we're going to be talking about nephrology and urology. We'll see what we can get through. The first topic we'll cover here is going to be chronic kidney disease, and so there are multiple ways that you can classify this, but most frequently it's going to be based off of the patient's GFR, so how you actually calculate that. Either Cockcroft-Gault or the MDRD equation, whatever you're using. But typically you look at things like the GFR to see how diminished the kidney function is for the patient. That will give you some idea of how decrease in function there, how much filtration is not happening essentially. And we'll see that there's quite a few complications that come about from that over the chronic period and some ways that we can help to treat that. Now, in terms of the reasons why patients develop chronic kidney disease, probably the most frequent one is going to be diabetes and then hypertension. So we know that chronically having high pressure there in the glomerulus, having diabetes, so these chronically high sugar levels, can eventually lead to damage to the glomerulus and inability to filtrate or to filter appropriately. But other things can happen with this as well, things like glomerulonephritis, smoking can be a contributing factor as well, obesity, etc. And so this is a pretty typical type patient you're going to see is, overweight, diabetic, hypertensive patient with poor kidney function, especially later on in life. So essentially what happens is these nephropathies that occur over a long period of time, and recall that the kidneys have a pretty decent amount of reserve function. It takes a lot of decrease in activity in a lot of these glomeruli in order to actually see a decrease in the creatinine clearance in the GFR because we have so much reserve function. But over time, you're going to see this loss of nephron mass. You're going to find this glomerular capillary hypertension, which puts more stress on the glomerulus, and then the proteinuria as you're unable to, or you're starting to filter more of that from the glomerulus, and you're also not absorbing as much as you normally should. And so we'll look at a few different kind of chronic complications that come about from chronic kidney disease and some ways we can manage that. One of the big ones is going to be anemia, and this is going to be related to the fact that patients with poor kidney function don't really produce as much erythropoietin as they normally would. And so you're going to find that it'll have this normochromic normocytic anemia. Again, the cells look normal, but it's just they don't have that stimulation to actually grow in the first place. And so that's why erythropoietin is necessary to provide that stimulus. You're also going to find that patients with chronic kidney disease typically have issues with both anemia and iron deficiencies related to several factors. So some of it is related to the fact that if they're going in for renal replacement therapy frequently, they're going for dialysis and they're having some blood loss related to that. Most of these patients are going to be on Monday, Wednesday, Friday dialysis, and so that's a lot of blood over time that they'll be missing. You're also going to find they'll have decreased uptake from the GI tract. You're going to find bioavailability of iron's already not great to begin with, but this gets worse with patients with chronic kidney disease. And also, if we're giving patients erythropoietic stimulating agents, and we'll talk more about those later, we're going to see that you have to make sure you're supplementing with iron because you can give patients all the erythropoietin in the world, but if they don't have good iron stores in order to produce new hemoglobin, it's not really going to do you any good. Other big issues that happen here are related to mineral and bone disorders in patients with chronic kidney disease. And so this can happen from a number of reasons that can include issues with homeostasis and calcium and phosphorus. You're going to see that over time, these will chronically be high in levels. And the more calcium and phosphate that you have, which can be evidenced by this thing called the calcium phosphate product, basically just multiply the two levels together. And if it comes up greater than 55, that means the patient's at increased risk for precipitation of calcium phosphate to occur, which can lead to things like tissue calcification. You can have emboli that can form because of this, so not a great thing to happen over time. We're also going to see vitamin D is going to be a big issue here because patients with chronic kidney disease cannot activate their own form of vitamin D. That 125 dihydroxyvitamin D just can't occur because the kidneys are not functioning well. And over time, you're going to see this leads to too much bone turnover. You're going to find that the bones will become, due to high PTH levels over time, it's basically kind of accelerating osteoporosis and develop overall what they call this renal osteodystrophy. Basically, due to decreased renal function, you're going to find that they have increased phosphate levels. And so as phosphate levels go up, it's going to start to bind up to calcium. And so that actually will decrease the serum calcium levels in the early phases here. having decreased calcium will then trigger PTH to be released, and so it'll do several things. It'll try to increase absorption of calcium from the GI tract. It'll try to help to reabsorb both calcium and phosphate from the kidneys, and it will then also try to mobilize it from the bone as well. And again, having low amounts of vitamin D also stimulates PTH as well. So all these things tend to cause a sort of sick cycle where as you are getting, say, for instance, more calcium being bound up by phosphate, that's going to increase more PTH release, which is going to mobilize more calcium out of the bones. And it happens over and over again until the patients can develop this renal osteodystrophy. And so some things you'll see with that means they can develop this parathyroid hyperplasia where they have actually more resistance. The calcium and vitamin D that actually may already be there, they may have relatively normal levels potentially, and the parathyroid just can't really respond to it that well. And then they get this high turnover bone disease where basically you can find that also you're going to get decreased erythropoiesis. You can develop kind of this bone marrow fibrosis, so it's less effective at producing those red blood cells, and then osteomalacia. So again, this is a chronic issue, and the earlier you can arrest this, the better it's going to be in terms of risk for these patients, both in terms of like anemias and fractures and things like that. So we're going to see that with our patients with chronic kidney disease, a couple things we want to do for them. So one, if we can delay or prevent progression of disease, that'll always be beneficial. This is why you want to do things like give your diabetic patients ACE inhibitors, for instance, because we know they tend to be nephroprotective. Once they do develop complications, we try to minimize those as best we can and hopefully try to limit the need for patients to either go on hemodialysis, peritoneal dialysis, or potentially kidney transplant. And then if we can also try to address any primary issues, whether it's their diabetes or hypertension, etc., maybe complicating, progressing their disease. So in terms of diet, we're going to find that a lot of the phosphate that we have in our diets actually comes from protein. And so we're going to see that also due to things like proteinuria and whatnot. For these patients, we try to limit their protein intake as best we can. So maybe about 0.8 grams per kilo per day, especially when their GFR is like less than 30. So that's pretty well diminished there. Other big things you want to think about as well is limiting their sodium intake, especially if they're hypertensive, mainly because this can worsen things like edema and blood pressure and all of that. And certainly, if we can get them to stop smoking and exercise more, that'll always be beneficial. So patients with diabetes and chronic kidney disease, as I've already mentioned, should be on ACE inhibitors or an ARB to help prevent further progression. Some things you want to note, though, especially with patients with decreased GFR, is you want to watch their potassium because they may be holding on to too much already due to poor kidney function. We know that ACE inhibitors and ARBs will then increase that further. So you don't want to make sure that we're not putting the patient at risk for, say, an arrhythmia potentially. We're also going to find that patients who are taking metformin should have this discontinued when their creatinine clearance gets below, say, 30 mLs a minute because of the risk for lactic acidosis goes up, which is a shame because it's a pretty good drug for those diabetic patients. It's just going to be a feature of that they can't clear it well enough, and that lactic acidosis can be fatal. So this is definitely one thing you want to make sure they are off. In terms of hypertension, typically you can shoot for pressures less than 140/90. We tend to see that proteinuria tends to decrease, and albumin excretion should decrease as you get lower and lower pressures there. And for the most part, they should be on ACE or an ARB, especially if they have diabetes mellitus, right? Typically, you'll find for these patients that a thiazide may not be effective in and of itself, and so you will oftentimes have to combine with other things like a calcium channel blocker or an ACE inhibitor, whatever the case may be there. Typically, though, you're going to find that their other disease states will dictate how you're going to manage their pressures anyway. So, for instance, they have like CHF or MI in their past, then things like ACE inhibitors and beta blockers and whatnot are going to be mandated anyway. And all those things can help out with the pressure as well. So for their anemias, how we can manage that, we want to make sure we're trying to increase their oxygen carrying capacity by getting those hemoglobin levels back up and try to decrease signs and symptoms of anemia. So things like fatigue and pallor and things like that, and hopefully decrease their need for transfusions. Again, giving a transfusion is not a completely benign process. You can have allergic reactions. There could be a low risk for transmittable diseases, but still there. So if we can avoid that, that's beneficial. And the way we do that is by giving ESAs or erythropoiesis stimulating agents and then supplementing with iron. And so basically we're going to be using our hemoglobin as our main way to monitor for that. So this is kind of an interesting thing here in terms of like the target hemoglobin. You really don't want to shoot for normal for these patients. So if you think about a typical adult patient, maybe in somewhere in the realm of like say 14 to 16 grams per deciliter, we definitely don't want to shoot for that high of a level. We'll talk about why that is in just a moment. But basically, you want to consider starting it when their patient's hemoglobin is getting down around between 9 and 10 grams per deciliter, and then we'll go ahead and discontinue it when they get up to around a level of say 10 or above 11 in renal replacement therapy patients. Again, these are patients on hemodialysis who are going to be losing blood due to frequent venous sticks and things like that. So that's why we shoot for a little higher amount there. Now, the reason why we want to monitor this so closely is because we actually find that as you increase the hemoglobin higher and higher, especially above 13 grams per deciliter, which looks pretty normal for many patients, there actually is a black box warning for things like cerebrovascular events, MI, and other things. Reason for this is because of the fact that as that hemoglobin gets higher, the blood actually becomes more viscous and it doesn't flow as well, kind of sludges up, so to speak, and so that can increase our risk for things like a CVA happening, NMI, other things like that. There are also some small cancer risk associated with these drugs, and so you do want to be cautious with that, but it's a low risk, as you'll see. And again, you're going to find that if the iron is not correctly supplemented, it doesn't matter how much of these ESAs you give, it's not going to do anything. So we'll talk about some ways to supplement that additionally. So the few erythropoiesis stimulating agents we have include epoetin alpha. This is frequently a brand name, Epogen Procrit, and then there's darbepoetin alpha or Aranesp. As I mentioned, the black box warnings have to do with death, MI, stroke, and VTE due to that sludging effect of the blood. And then, of course, because we are stimulating these cells to replicate, this could increase the risk for some cancers, things like breast cancer and whatnot. So this is another thing you want to screen for, especially if they have like a high-risk history. In terms of dosing, it can vary depending on the agent you're giving. For instance, like darbepoetin can be given every 4 weeks versus epoetin maybe every 3 times weekly. Just depends. Certainly you want to watch out for things like hypertension, which can be worsened here, and then also vascular access thrombosis. This means that the patient has like a fistula for dialysis, or maybe they have like a port that's implanted subcutaneously. These can be at risk for clotting off, and so you want to be cautious there because that may mean that you have to lose the line, or it could mean that you have to use a thrombolytic in order to treat that. So definitely one thing we'd want to watch for. In terms of their iron status, you want to see that this is going to be maintained along with other cofactors for producing hemoglobin and red blood cells like B12 and folate, which can be diminished in patients who are on dialysis. And we're going to see that for many of these patients, that iron absorption bioavailability is not going to be great, and so we may need to look at some other ways to supplement that. In terms of oral preparations, here are a few you're going to run into. This is not an all-exhaustive list for sure, but here are the most common ones, including ferrous sulfate, ferrous gluconate, and then ferrous fumarate. And there's also some IV preparations. And so obviously the benefit of IV is that it's going to have 100% bioavailability. And so we have some different options here, including iron dextran, sodium ferric gluconate, iron sucrose, and then ferromoxitol. So there's a lot of adverse effects associated with iron supplementation, especially with the orally administered products here. There's a lot of GI complaints, including a lot of constipation, nausea, abdominal cramping, and you'll find most patients will be complaining about this, and is a good reason why a lot of them will stop taking it, whether at your behest or not. It's also important to make sure patients know they could have a blackened discoloration of the stools because you do worry about like GI bleeds if you were to see that, but it's a pretty typical side effect of iron. In terms of IV formulations, and this may be good for patients who have tried oral supplementation, but it's just not really sufficient, this is where we can use our IV formulations. And so things to watch out for include things like allergic reactions, and then we can also see with quick infusion times, things like hypotension, dizziness, and headaches. And so we can go ahead and just slow down that infusion rate, and that will certainly help to decrease a lot of these kind of cardiovascular symptoms here. Other things like arthralgias and arthritis are pretty common as well. So typically we like to use oral therapy because it has fewer side effects from a systemic standpoint. It's cheaper. And so basically you're going to maybe play around with different products to find out which one works best for your patients there. If they're on renal replacement therapy, quite frequently they're going to require IV iron supplementation just because there's no way they can absorb enough from an oral standpoint. And so they may come into the dialysis center and get their dose of IV iron at the same time potentially. So kind of get a 2-for-1 sort of thing. In terms of monitoring, you want to go ahead and monitor iron status basically every 3 months while they're on an ESA, or certainly if they're titrating the dose of the ESA, then you can go ahead and monitor more frequently there. And then typically we'll monitor the hemoglobin about every 3 months or so. But if they're on renal replacement therapy, they're coming in Monday, Wednesday, Friday dialysis, when they may check it more frequently, like say every month or so. And then again, remember that cutoff point when you want to cut off the ESAs is around, say, like 10, 11 grams per deciliter of hemoglobin. In terms of helping to manage their mineral and bone disorders related to the chronic kidney disease, essentially what we need to do is to try and regulate their calcium and phosphate levels, monitor the PTH levels, and also get their vitamin D under control. So we're going to look at some ways we can help to manage that. One of the biggest things you can do is try to limit their dietary phosphate intake. And so this is first line management, because if you can get that phosphate under control, that's going to prevent that phosphate from binding up all your calcium, and those should help to regulate those levels a little bit better. The higher calcium levels will help to decrease PTH levels, and that helps to keep the bone from being mobilized, calcium from the bone being mobilized so much. So this can be tough to do to get their phosphates under control, mainly because you're going to find there's a lot of high phosphate foods and drinks out there that you may not think about. So things like dairy products and meats and peanut butter, even like colas and beers and things like that, tend to have a lot of phosphate in it. And so the other thing you're trying to balance out here is the fact that while we mentioned protein restriction may be beneficial for some of these patients, typically when they're on dialysis, they're kind of chronically stressed from a medical sort of standpoint, and so they actually require higher protein intake. So you're trying to balance out giving them more protein because you don't want them to make sure they're maintaining their lean body mass and whatnot, but you also don't want to have them get overloaded with phosphate. So pretty tough, and you'll find that dialysis itself is not great at pulling off phosphate in sufficient quantities. For some patients, may actually find they'll just go ahead and remove their parathyroids if they're not responding very well to pharmacologic therapy, but let's look at the meds we can use potentially to help prevent that necessity. So here at the phosphate binders we'll use, these are all going to be oral products we'll give the patient, and typically these are better taken around mealtime where they can actually bind up most of the phosphates that are coming in. So we have things like calcium carbonate, which we know to be things like Tums and whatnot. It's a typical antacid. First line therapy, because it's cheap, it's easy to get access to, right? But say that's not effective enough, we can go with things like calcium acetate, which is known as Foslo, and then we have some non-calcium based products. These would be better for patients who maybe have hypercalcemia as a result of their kidney disease, and so this include things like sevelamer, lanthanum, and then aluminum hydroxide. We're going to see aluminum hydroxide we've talked about before in terms of its use as an antacid, but it also works as a pretty good phosphate binder. We'll see, though, that there's some downsides to using it, especially in patients who are on hemodialysis. So patients are likely to respond better to calcium-based agents early on because likely they're hypocalcemic due to those high phosphate levels. We'll see the calcium carbonate is typically more soluble in those acidic mediums. So this is why we give it prior to meals when your stomach is starting to sort of increase acid production there. Sevelamer may have some effects on your cholesterol, so it could have some positive effects, which is nice from that standpoint. But of course, it'll be more expensive than something like your typical Tums. And then we don't use aluminum-based products as widely anymore. The reason for that is because, especially when you have chronic kidney disease, you have a tendency to accumulate aluminum, and normal aluminum levels should be basically zero in the body. So as you accumulate that, it can actually lead to some neurotoxicity. So we definitely want to avoid that if at all possible. Typically used for more kind of short-term sort of management of that hyperphosphatemia. So typically, as we'll see that, with that, GI effects are going to be a big one here in terms of calcium supplementation. Remember, calcium products cause constipation already, and especially if they're trying to get their iron in and their calcium. Remember, these can bind up together, so you have to make sure you're trying to separate them out in terms of time-wise. It gets complicated pretty quick for these patients here. Again, obviously, hypercalcemia may be at risk, especially later on. This may prompt you to switching over to something like sevelamer or lanthanum potentially. And then I would watch out for that aluminum toxicity. The reason why it can worsen anemia is because it may compete with absorption sites for iron, and so because of that, obviously we can't use aluminum to form hemoglobin, so that's why it can worsen that anemia potentially. In terms of drug interactions, as I mentioned, calcium salts are going to bind to a lot of things, so fluoroquinolones, iron, etc. So you want to make sure you're separating these out. Either give the other product an hour before or 3 hours after. So make sure that's you educate on that for your patients with chronic kidney disease. In terms of vitamin D therapy, we're going to see that the typical vitamin Ds that we ingest, ergo and cholecalciferol, they have to be converted first in the liver to the first hydroxy form, and then it goes down to the kidneys to get the second hydroxy conversion. So that's the calcitriol that we see as the 125 dihydroxy vitamin D. That's the active form. And you're going to find patients with poor kidney function cannot form that calcitriol, and that is going to be leading the parathyroid to say, hey, there's not enough vitamin D around here. Let's go ahead and try to absorb more calcium from the kidneys and from the GI tract and all of that, and from the bone. So you're going to find that if you can't get the vitamin D levels under control, this is going to worsen the hypercalcemia and the hyperphosphatemia in patients who are a little bit more progressive in terms of how diminished their kidney function is. So calcitriol is what we're going to use if they cannot form the 125 dihydroxy vitamin D on their own, because otherwise you can give them ergo or cholecalciferol all day long. Nothing's going to work for them, right? You have to replace it with the calcitriol. There's a few other agents here. So say, for instance, we have a patient with already high levels of calcium and phosphate. Well, calcitriol can actually worsen that. So what if we did something that maybe activated the PTH receptors to make it think there's enough vitamin D, but didn't actually do anything to increase calcium and phosphate? That's where paracalcitol comes into play. If you had someone with the high levels of phosphate and calcium, paracalcitol is a better option than calcitriol for those patients there. But if maybe the calcium is low, calcitriol may be a good option for them. There's another one called cinacalcet or Sensipar. This actually helps to sensitize the PTH receptors to the effects of calcium. So basically the calcium that's there works better because the parathyroid is kind of sensing it more. So this will help to decrease PTH concentrations through that negative feedback loop you see there. So those are the main ways we're going to help to manage complications of chronic kidney disease for those patients. Next up, I want to move on and talk about some urology topics, and we'll start off with erectile dysfunction here. So typically it's defined as the inability to achieve an erection that's suitable for intercourse for, say, 3 months or so. Another term for this might be impotence, you'll see there. Note that this is different than patients who have like a decreased libido or infertility. This is mainly the actual physiologic act of developing an erection is the issue for these patients here. So you're going to find that if someone's depressed and they don't want to have sex anymore, that's not going to be what we're talking about here, essentially. There are other ways to help to manage that. So looking at the physiology, we'll see here that in the penis there are 2 corpus cavernosum here, and normally during resting flaccid state, there's pretty good balance here between the venous and the arterial flow. So the amount of blood coming in is equal pretty much to the amount of blood coming out. When the stimulation occurs to cause an erection, you're going to see that there is going to be increased arterial flow. So there's going to be some vasodilation that occurs that allows more arterial blood to come in, but we're going to decrease the venous outflow such that it causes that engorgement to occur because basically more blood is in the area there, and that's causing that enlargement. So we're going to find that there's different ways to manage this system here. So for instance, with arterial flow, we're going to see that things like acetylcholine actually help to mediate some of that vasodilation. So things like cyclic AMP get formed, things like CGMP get formed, all that help with causing the vasodilation to occur. Ultimately, these help to stimulate the nitric oxide pathway, and so this is a really important thing here for our medications because we're going to see that by increasing levels of CGMP, this actually decreases calcium coming into the vascular smooth muscle. Less calcium coming in causes the smooth muscle to relax because remember, calcium stimulates smooth muscle contraction. So decreasing that helps it to relax, and that allows more blood flow coming in. We're also going to see that there's a prostaglandin that also helps enhance cyclic AMP formation. This will be really important for an alternative agent we'll talk about later on. So, of course, it's not just the amount of blood flow that's occurring here that changes. There also has to be some sort of psychogenic stimuli that occurs here, and there's a pretty complicated sort of reflex arc that happens that sends nerve impulses down to actually stimulate the erection itself. And so, for instance, you can see things that in order for the brain to sort of process external stimuli and turning them into signals to cause an erection, you're going to find that things like dopamine helps to exert these kind of pro-erectogenic effects, right? Whereas if you were to stimulate, say, alpha-2 receptors, like with norepinephrine or something, that actually can inhibit erections from occurring. So there's some balances here, and you might imagine how patients, say, for instance, with like a dopamine antagonist may have issues with developing erections because of we're blocking the dopamine effects, and you don't have that issue there, right? Also, we'll see that detumescence, or when you're going back to the flaccid state, that will be mediated by norepinephrine. Basically, this is going to contract that vascular smooth muscle by acting on those alpha receptors, and they'll decrease arterial flow. And then at the same time, venous outflow will increase as well, unless you go back to kind of the normal resting state. So looking at hormones and how this actually plays a role as well, we're going to see that testosterone and its byproduct of the 5-alpha reductase enzyme DHT, it can have effects on things like libido. And we know that testosterone levels typically will diminish over time, especially after the age of 40 or so. 5-alpha reductase is also really important in terms of the prostate, which we'll talk about a little bit more later on. Due to the activity of the enzyme aromatase, you'll see some of this testosterone being converted to estradiol, which may be responsible for some of the feminizing effects you can see. So you have a patient who's converting a lot of estradiol or a lot of testosterone to estradiol, they can see those kind of feminizing sort of effects there. And it's really important that if you have patients who are complaining about erectile dysfunction, to carefully interpret those testosterone levels, because you may find that they may be normal. They may have issues where free levels may be diminished, even though total levels may be normal. And of course, it's important to kind of distinguish between decreased libido, whereas you just don't want to have sex, versus erectile dysfunction, where they may have the urge to have sex, but basically they cannot achieve that erection. So those are two different problems, and which usually can be elucidated by talking to the patient. So looking at the pathophysiology, like why do we get erectile dysfunction? We're going to see that a lot of it's just kind of organic, just kind of naturally happens over time, but some of it could be related to some other issues, things like vascular disease. You may have things like neurologic complications of, say, like spinal cord injuries. That way that reflex arc never happens to stimulate the erection in the first place. Diabetes causing microvascular complications or causing neuropathies. And then just with hormonal changes, either aging or hyperprolactinemia. Remember, when you have high prolactin levels, that decreases dopamine activity, so you can see how that can be an issue. Or even if you had, say, testicular cancer and you had removal of the testicles, that could lead to this as well. There's also psychogenic erectile dysfunction, which may be related to things like anxiety or depression. Again, it's not going to be treated the same way as you would see with typical organic sort of erectile dysfunction there. And frequently, it could be multifactorial. It could be multiple things going on that you want to help to all kind of manage at the same time. So in terms of the proper frame of mind for these patients, you may find that things like depression or performance anxiety may inhibit the patient from being able to perform. And again, it's not that the actual physiology is not working, it's just they may have sort of mental blocks that may be helping to prevent this. And of course, that is going to be treated differently than you would see if it was just a typical organic sort of erectile dysfunction. But things like Alzheimer's disease, hypothyroidism, all could be playing a role. And you want to make sure you're screening for these and ruling things out as appropriate when helping to kind of formulate your plan for your patient. So it's important to understand that medications can also be a source for erectile dysfunction, and you can actually find this in up to 10 to 25% of cases, could be related to medications a patient is on. So for instance, like anticholinergics may make it more difficult in order to achieve an erection, either due to sedation, mainly because if you can't really process external stimuli that, hey, it's time to have sex, that could be a problem. And you can see this with either antihistamines, TCAs, phenothiazines, all of these can be an issue. You'll typically find, and we've talked about this before, that in terms of sexual dysfunction, TCAs tend to be the worst, whereas your SSRIs, SNRIs are a little bit better. Bupropion is going to be the best for patients who are having sexual dysfunction related to their antidepressants. As I mentioned, dopamine antagonists like your phenothiazines all can lead to decreased activity of dopamine. Also, having the high prolactin levels makes it more difficult to achieve an erection, and that also can affect your testosterone levels as well. Right, so again, it's important to screen for medications to see if there's anything that could be kind of contributing to their issues. Things like anti-androgens or estrogens can all be playing a role here as well. These can help to suppress testosterone levels, leading to decreased libido. And then CNS depressants is a very common one you're going to run into. So things like alcohol, benzodiazepines, opiates. Again, if the patient has a suppressed perception of psychogenic stimuli, say, for instance, they're passed out, they may not be able to achieve an erection in those cases there. So pretty common thing is to think about patients who maybe are drinking too heavily and are unable to perform. It could be related more to the CNS depressant effects than anything from the actual physiology of the patient themselves. So other medications that can decrease penile blood flow, this typically is a lot of your antihypertensives, and this is a pretty common complication of most antihypertensive drugs. So either diuretics or beta antagonists, all of these can do that. Overall, you're going to reduce arteriolar flow to the corpora cavernosum and thus have the inability to achieve that erection. This is less likely to be seen with things like ACE inhibitors, ARBs, and calcium channel blockers, so it may be a good option to switch patients over to one of these if their other disease states sort of allow for that. and kind of random drugs as well that can maybe cause issues, things like finasteride and dutasteride. We'll talk about these more when we get into BPH, but these decrease overall androgenic activity of DHT. Lithium, MAOIs, a lot of different agents that may have some miscellaneous effects to decrease either libido or the ability to achieve an erection. Again, it's always good to screen their profile and see if any of them could be contributing. So obviously, get the good history from the patient, get their medication list, and figure out if any of their concomitant disease states may be affecting their ability to achieve an erection. You can check testosterone levels as well to see if that may be contributing. In terms of treatment, our goals are mainly to try to increase the quantity and quality of suitable erections for the patient, make sure they have reasonable expectations, and the fact that say, like, okay, well, this is not going to be, if the issue is more related to their depression, then giving them a medication to help with the actual erection itself may not be the thing that's going to work for them. And so you have to kind of come up with expectations to see, well, what do you need to work on in terms of, is it more of a mental health issue? Is it more of a pathophysiologic issue? Come up with those expectations. Make sure you only have patients with legitimate complaints. So again, this is a popular class of drugs to potentially abuse by male patients who maybe don't have actual erectile dysfunction to help increase performance. We actually treat many of these medications as a controlled substance in our hospital vaults, mainly so that way we don't have diversion by healthcare workers and whatnot. So it's kind of odd thing to see something like Viagra being kept locked up, but it's one of those things where it tends to walk off if it's not being managed more appropriately. Again, hopefully have something that's well tolerated and pretty reasonable in terms of cost. Again, this is more of like a lifestyle set of medications, and so in terms of insurance coverage, this may be something that is may not be covered by your patient's insurance, and so we want to find something that is reasonably cost effective for them. So we also want to correct any underlying disease states that could be affecting this. So like get their hypertension, their diabetes, alcoholism, anything like that under control. Look at their mental health issues and try to get those under control as well. And then we'll see there's a couple of different options when you're actually treating the erectile dysfunction itself. And you can go anywhere from, say, vacuum erection devices all the way up to surgery. I'm not going to focus on those very much because, again, they're kind of outside of my wheelhouse. I will focus on pharmacologic therapy because, again, this is your pharm class. So these drugs should be have a fast onset. They should be efficacious, obviously convenient, and have hopefully limited side effects for these patients here. And we'll talk about drug interactions, especially some really life-threatening ones potentially that we want to avoid. And we generally want to go from things that are least invasive to most invasive. And so, for instance, starting off with a tablet may be the easiest thing because, again, it's less conspicuous. It's not very invasive, all the way up to like surgery where you're actually implanting, say, a prosthesis or something like that. It just depends on the patient, but typically we'll go with oral therapy to start with. So, and looking at this, we can kind of see the general flow of things in terms of how we're going to be managing these patients. So first off, obviously look at treating the underlying diseases and discontinue medications that may be contributing. And then we'll look at our phosphodiesterase inhibitors. This is going to be the main class of drugs we're going to use to treat erectile dysfunction first. And then we'll see how they respond to it, right? So we're going to try to make sure we're optimizing our dose and see how they're going to respond. If they are contraindicated from receiving these, and we'll talk some reasons why that may be. This is where we may look at things like vacuum erection devices. And again, looking down the line, we'll see that if the phosphodiesterase inhibitors are not working or if they're not going to be able to use something like a device here, we'll look at some intracavernosal or intraurethral options. So this is another class of drugs we'll talk about later. And then we'll see how it works. And then we may go with multiple medications or we may actually go with a penile prosthesis. It's actually one thing I saw with, I had a student who was on rotations and he was at a urology office and he found that a lot of the older patients, they didn't even want to mess around with the medication. They just want to go straight to the prosthesis. Again, you can look up more information on that, but it's kind of like a moldable device that's in place. You basically can just like change the shape of it and go from kind of a more flaccid state to more erect state pretty easily there. So they're like, I don't even want to mess with the drugs. Let's just go ahead and put in the actual prosthetic. So some patients want to do that. Just depends on their proclivities. So again, with the vacuum erection devices, this is probably the least conspicuous out of the bunch, mainly because it's got a big device so you have to manage there. Typically, you're going to find that most patients respond well to this. However, you're going to see that it's not very discreet, but it does have a pretty fast onset. We'll look at some other issues of onset a little bit later on. These are going to be good for patients who may not be able to utilize medications due to either drug interactions or comorbid conditions. And you can also potentially use it in combination with drug therapy prior to surgery. So some patients may want to try this. Some patients may be pretty embarrassed about it and not want to try it at all. Just depends on the patient. But getting into the phosphodiesterase inhibitors, these are sort of your drug of choice, sort of your most typical agents you're going to be using for management of erectile dysfunction. And so basically how these drugs work is that in the normal scheme of things, and we'll see how this is the kind of the normal process, and we'll see how our drugs interact here. But normally you'd have sexual stimulation of the patient, right? So thinking, okay, it's time to have sex. They will then, through that sacral nerve reflex, they're going to release nitric oxide onto those endothelial cells on that smooth muscle. Nitric oxide then will stimulate guanylate cyclase, and so you end up getting increased levels of cyclic GMP. Overall, you're going to find that cyclic GMP is going to help to decrease calcium influx into the smooth muscle. Decreased calcium means less constriction, meaning you're going to have vasodilation occur. Okay, so you're going to have more blood flow coming in, and that develops the erection. Normally what happens is that cGMP gets catabolized by phosphodiesterase. It's an enzyme specifically designed to metabolize cyclic GMP, and then when that occurs, eventually you get back down to the resting state. So there's a balance here between nitric oxide stimulating formation of cyclic GMP, and then you have phosphodiesterase that is metabolizing it. Well, what happens if I were to, say, inhibit this process and try to decrease the activity of the phosphodiesterase? Well, you end up having an overabundance of cyclic GMP, which helps with more of that vasodilation, and then hopefully you're able to produce a suitable erection, right? And so here are the different agents we'll see in this category, including sildenafil, vardenafil, tadalafil, and then avanafil. And so you can see their brand names here. And basically, these are going to be competitive antagonists of phosphodiesterase. And so the main one we're going to be seeing here, and of course, phosphodiesterase has multiple isoenzymes in the body. We're going to find that the main one they work on is this PDE5. This is the main one needed for developing an erection. However, they're not completely specific to that one. We'll see what the consequences of that are when they are working on other types of phosphodiesterase enzymes. And so I would expect you to know which one of these are responsible for different side effects or which one of these are responsible for the clinical effects, because again, it may make a really big difference in terms of which one of these you pick based on their selectivity for different phosphodiesterase isoenzymes. So here's a nice table you can kind of go through and look at the difference in terms of their effects on different isoenzymes of PDE. You also see that they have differences in terms of bioavailability and half-life and whatnot. One of the big things that I would want to point out here is the plasma half-life here. You can see that most of these work for relatively short periods of time, except for tadalafil. This one has a clinical duration of like 36 hours or something like that. So this is one of those things you could take on a Friday evening, and you're kind of good throughout the weekend for the most part. Whereas some of these other agents like sildenafil, you may have to take, say, multiple times throughout a given set of days or so. Again, you can see down here the duration in terms of hours, how long they're going to be lasting. Tadalafil being obviously the winner here in terms of long-acting effects. In terms of onset, you can see for the most part between 30 minutes to an hour or so for most of these to kick in. So you have to let the patients know. Don't just take it immediately and expect that you're going to get an erection. Like, you have to give it time to really absorb and kick in. So as I mentioned, these are going to be first-line therapy, especially for younger patients. They typically don't have a lot of contraindications to receiving these. They're very discreet. It's basically just popping a pill. And then you're going to select your agent based off of the adverse effects, the onset, duration, and also the cost of treatment. I would frequently have, and this is back when sildenafil was really kind of the first one out on the market and it was still brand name only. And I would have patients who would come in, usually as like working as an intern at the CVS, like on a Friday evening. And they would come in and they would basically just pay cash for one pill, and that's all they wanted. Usually they're coming in dressed to the nines, or probably about to go out for a nice date, and that's all they wanted, right? They didn't have the money necessary to afford a full prescription's worth, which is totally fine, right? That's all they need it for, and that's what it is. But ideally, we want to find something that's going to be cost effective for the patient there. And most patients do respond pretty well to this. If they don't, it's frequently because they have comorbid conditions. So either mental health issues or diabetes or something like that that may prevent it from really working all that well. So in terms of therapeutic failures, you may want to look at things like food interactions. So for instance, absorption may be affected for things like sildenafil and vardenafil based off of, if they're eating with fatty foods or not. And you want to make sure you're giving your patient several doses to try and see how they respond to it. Obviously, you want them to avoid excess alcohol because that can decrease their response to external stimuli. So that's one thing to note there. And then you really want to be careful in using this in patients either that are healthy at baseline, they have no problem developing erections on their own, or if they have anything that may affect blood flow, it may cause any kind of increased viscosity, things like sickle cell disease or leukemia, or if they're on other erectile dysfunction therapies, because it does increase that risk for priapism. And again, priapism is sort of that unnecessary erection that's around for a long period of time. The issue with that is having all of that decreased flow of venous blood, and you have the increased arterial flow, is that eventually that can lead to decreased oxygen supply to the tissue, can lead to tissue necrosis, and it's considered a urologic emergency. And so frequently patients, if they develop this, have to come into the ER, and they can either they manually drain it, so either via needle aspiration, or we can actually use a vasoconstrictor, something like phenylephrine, that you can actually inject into the cavernosa, and that will help to actually cause squeeze of those arterial vessels and decrease the erection. So obviously this is something we want to avoid if at all possible. So as I mentioned, there's other isoenzymes out there for the phosphodiesterase enzyme itself. So for instance, PDE6 is found in the rods and cones of the eye. So if an agent has more, say, specificity for PDE6, this can lead to specific side effects, things like blurred vision and cyanopsia. So you actually end up developing sort of a bluing of the vision, kind of like a blue, kind of like we talked about xanthopsia, like a yellowing of the vision you see with digoxin. This one's actually a blue discoloration. You'll see sildenafil is probably going to be the most likely one to cause visual side effects. It's kind of funny because you always think about sildenafil being the little blue pill, and it can actually cause your vision to go blue too. So I don't know if that was intentional or not, but it is what it is. You also see that PDE11 is really localized to the striated muscle, and so this is going to be affected mostly by tadalafil and frequently leads to myalgia. So the patients complain that they felt like they just ran a marathon or something, like it is typically related to this PDE11 effects. In terms of onset, you're going to find that sildenafil and vardenafil are going to have a little bit slow onset when they're consumed within 2 hours of food or so. So usually about an hour or two is going to be onset for most of these. And as I mentioned, tadalafil has the slowest onset, but it does have the longest duration. So they would want to take this a little bit sooner before the anticipated time of intercourse. But you want to make sure that they're going to be aware that you may not need to take another dose of this or whatever time period. It does work for about a day and a half or so. Note that these are metabolized through CYP3A4, so you do want to watch out for any drug interactions that may increase those levels and increase your risk for things like priapism, right? You want to watch for that. And then some of these should be renally adjusted as well. So in terms of adverse effects, frequently this is related to the vasodilatory actions of the drugs, and so you can imagine if I cause vasodilation in the cerebral blood vessels, you can see headache that can occur, similar to like a migraine almost. Facial flushing and dyspepsia. Imagine if you have the lower esophageal sphincter loosening up due to this inhibition of phosphodiesterase, that can lead to reflux occurring there. They also can get like nasal congestion and dizziness. That's another thing that is related to that vasodilation there. You can see drops in blood pressure, so about 8 to 10 millimeters of mercury. So most patients are not going to have an issue with this, but say if they're on multiple antihypertensives, or maybe they're also on nitrates as well, and this is going to be a big interaction we're going to look at later, you want to watch out for this. You could bottom out the pressure and increase the risk for things like syncope potentially. And then use really cautiously in high-risk cardiac patients, because you do you'll want to be really cautious with them based on the fact that you don't want to bottom out their pressure, potentially cause decreased myocardial oxygen supply. Just want to be cautious, right? Make sure you're covering this with their cardiac provider as well. In terms of adverse effects, again, photophobia, blurred vision, loss of kind of blue-green color discrimination. This is something you're generally going to see related more towards sildenafil, because it has most of the activity at PDE6. Generally, this is reversible, but there is sort of an emergent sort of thing you'd want to warn the patient about, and this is non-arteritic anterior ischemic optic neuropathy. Kind of a mouthful, but basically they can get this unilateral blindness that can occur and may be irreversible, right? So this is something that may occur with the first dose, or could happen years after the fact, but is actually related to having this drop in blood flow to the optic nerve. So if it's caught early and you can hopefully decrease or discontinue further administration of the drug, then it may be reversible, but in some cases it could just be irreversible and they're blind now. Tadalafil is most likely to cause myalgias, and this is mainly due to the fact that it has the most activity at PD-11. And then vardenafil can cause QTc prolongation, so you wouldn't want to be cautious there. Maybe they're on like antipsychotics or an antiarrhythmic that could prolong QT. This would be a risk for those patients. And typically, priapism is rare, but it's going to be associated more often with like really high doses they're receiving. Young patients who really don't need it are receiving it, or if they have concomitant use of other erectogenic drugs. So if they're using something like alprostadil or a vacuum pump or something like that, could lead you to more risk for having this priapism. So drug interactions are important here. So nitrates are the biggest one. So if a patient who's on nitroglycerin or they've taken a long-acting nitrate or something like that, if they mix this with a phosphodiesterase inhibitor, it can lead to severe hypotension. Okay, and in fact, use of the two together should be contraindicated, mainly because you're going to find that nitrates give nitric oxide that stimulates cyclic GMP, and then now I have something like sildenafil that blocks the breakdown of cyclic GMP. So way too much cyclic GMP being formed and way too much vasodilation leading to that hypotension. Okay, really want to be cautious with that. And basically, you want to make sure that the patient has not received nitrates within a 24-hour period after using a phosphodiesterase inhibitor, and actually it's even 48 hours for tadalafil because that's a long duration of action. And so if you need to treat a patient with angina, you can use other agents, maybe a beta blocker, maybe a calcium channel blocker. If this does occur, though, if they got the two together, you can go and put them in the Trendelenburg position, where basically you'd have the head down, the feet up, and give them lots of fluids to help fill the intravascular space. So big thing to think about here is, especially with like emergency medical services. So imagine an older gentleman has a history of angina. Maybe he's taking isosorbide mononitrate for his angina, and he's having sex. And guess what? He's physically active. All of a sudden, he develops chest pain. They call 911, right? So normally EMS would arrive. They hear a guy has chest pain, cardiac history. They're going to give him nitrates, right? The problem is if he's taking a phosphodiesterase inhibitor, you got to be really cautious there and make sure that EMS is asking that question, because if they don't and they cause this interaction to occur, they could really bottom out the patient, lead to maybe an MI, maybe lead to syncope. Not great. So we want to make sure you're definitely screening for those sort of thing there. And it's usually pretty typical for them to ask questions of the right patient population. Be cautious with CYP3A4 inhibitors. If they are on board, we can just use lower doses of your sildenafil or something like that when starting out. So in terms of alternative agents here, there's one called alprostadil, which is basically prostaglandin E1. And so it comes as this either as an intracavernosal injection, either known as Caverject or EDEX, or as the intraurethral insert. And so it's called MUSE. It's called the medicated urethral system for erection. And so basically what this is doing is instead of affecting cyclic GMP directly, it actually will stimulate adenylyl cyclase as you increase cyclic AMP. This will also lead to that smooth muscle relaxation. And again, this is not a pill you're taking. It's either going to be an intracavernosal injection, or it's actually going to be a small suppository that will be inserted into the urethra itself. So working very locally. And so because of that, you're not going to find that, one, it doesn't rely on the nitric oxide pathway. So it could be good if patients are maybe either taking, say, nitroglycerin, but it's also going to be good for patients who you may not want to have those effects on their blood pressure. You want to have systemic effects. It just works right there in the penis itself. So you're going to find that has pretty good bioavailability because it is, directly being injected in those cases there, and it's preferred over some of the other agents they've used in the past. This drug itself has less risk for things like priapism from occurring, so that's kind of the benefit to using these. And most patients do respond well. It's just a matter of fact that most patients don't want to inject themselves in the first place, especially not in the penis. So, definitely something you have to have a conversation with your patient about. Pretty short acting and pretty quick onset here, so you want to make sure patients know that in terms of like when to actually use the medication to make sure that they don't use it too early or too late potentially before it really has a chance to kick in. Typically, if it's related to something like psychogenic erectile dysfunction, they tend to respond a little bit better than if it was more of a vascular issue there. And then you'll see that tolerance doesn't really tend to develop, so they can continue using the same dose that works for them really with no issue. Typically, patients will discontinue this due to things like needle phobia or inconvenience, or if it's costly. It tends to be more costly than something like a typical phosphodiesterase inhibitor. So these are common reasons why they will stop taking it. So when you're doing the injection, it should only be injected into one side of the penis on one cavernosa there. And again, the duration of action is relatively short, so they shouldn't expect it to last, say, more than an hour or so. And again, very limited side effects because it has limited exposure to the systemic circulation, because that's a pretty quick half-life. They'll typically use it within 5 to 10 minutes prior to intercourse, and they'll use a pretty high gauge short needle here. This is really important to make sure they're using aseptic technique to avoid developing a secondary skin infection or something like that. So typically the local effects, things like pain and whatnot, are going to get better as their injection technique gets better. But you do want to make sure that they are kind of rotating sites a little bit, because it can develop some fibrotic areas. And if it does develop, they can kind of discontinue use until that does resolve on its own. But typically, some injection site pain, some burning discomfort, things like that are pretty common local side effects, but really nothing systemically to speak of. Priapism is a risk, although it's fairly low risk for these patients. In terms of the intraurethral injection, the only difference here is that there is risk for things like stricture or difficulty voiding. This may be related to like actual physical trauma that occurs from using the device to actually place this into the urethra. So if you have patients who already have difficulty voiding, this may not be a good option for them potentially. And then there's some prostheses, either inflatable ones or ones that are malleable. Patients do tend to respond to this pretty well, but this is typically going to be reserved for patients who have either failed oral therapy, or they really just don't have an interest in using any other options, and they may just go with this. Especially if they're like older and they have a lot of comorbidities, this may be a good option for them. All right, so we're about at the halfway mark, so I think I'm going to go ahead and cut it off for this particular video. And then for next week, we will check out the second half of the urology talk and get through BPH, and then also talk about incontinence. If you have any questions in the meantime, though, let me know, and I'll talk to you soon. Thanks a lot. Bye.